Good morning, everyone. I would like to invite Dr. Azmi Alias, Head and Senior Consultant Neurosurgeon at the Tunku Abdul Rahman Neuroscience Institute Hospital, Kuala Lumpur, Malaysia, and Dr. Atul Goel, Professor and Head of Department, Chief Neurosurgeon, Tata Memorial Hospital and Cancer Research Institute in Parel, Mumbai, to kindly come on the stage and chair the first scientific session.
First of all, these affiliations are a little bit not correct, so I will correct them later. First and foremost is welcome Dr. Azmi and everybody. So let's begin the show. What do you think? And let's have a 2-day celebration of minimal invasive neurosurgery. It is the in thing, it is the future, it is for the better of the patient. It is for success of the operation, and we have to do it and we have to learn it. It is a new thing in neurosurgery, possibly the better thing in neurosurgery, that we have to find out whether it is better or it is a clutter in the operation theater. So the first lecture, which is very important, debate on craniopharyngiomas. Craniopharyngioma, in my estimation, is completely an enigma of neurosurgery. It is a benign tumor, but nobody knows what will happen the next day after surgery. Like chordomas, it has been histologically quite good, but nobody knows what will happen after 10 days. So these two entities are completely mystery in neurosurgery. And this mystery, if we can little bit solve here and there, that will go further in our subject. So to solve this mystery, particularly as to how to handle them during surgery, whether to come through the nose, when to come through the nose, whether to use endoscope, whether use microscope, or to come transcranial, we have got two fantastic speakers on the subject who are well known in the field, not only in India but throughout the world. And first is Dr. Shekhar Devpujari. He will talk about how to handle craniopharyngiomas and whether endoscope is the way to do it. Shekhar Devpujari.
Thanks Atul and Dr. Azmi. Can we switch on to the other computer? Great. So I think the wording used in my title is endoscopic approach is the best. I would try to just take you through in the next 12 minutes or so as to what it has contributed, and I think the audience can probably make their own judgment. Basically, we recently wrote about this in one of the operative neurosurgery books, where we have enumerated that endoscope has offered not only endoscopic endonasal excision of the tumor, but it also helps you in palliative procedures like endoscopic cyst fenestration, drug instillation, neuroendoscopic transventricular excision, and combined approaches as well, and as an adjunct to microsurgery. So I think it has several contributions. And just to remind people that the first craniopharyngioma probably was removed by Halsted in 1909, which was by the transsphenoidal approach, though it was not either microscopic or endoscopic. Basically, how we treat these patients depend on how they present, and the presentation can be endocrine, ophthalmic, or raised intracranial pressure. And the aim of the treatment always remains to improve vision, which is usually the presentation in our country, and to decrease the ICP, and cure from the tumor. Maintaining a good functional status remains the goal, but I'm putting it as the final goal. Choice of treatment is surgical excision, which is a well-known treatment. Radiosurgery and radiotherapy, various forms, have become important part of this. Since 1960s, we know radiation works in this, and intracystic therapy is also becoming very popular, especially in very young children. The areas of controversy in surgery, of course, is the extent of surgical resection, which we are not going to discuss today. We are mainly going to talk about the surgical approach, and use of adjuvant therapy is a separate topic altogether. We have known that craniopharyngioma is of two varieties, adamantinomas and papillary by histopathology, but recently we also know that molecular biology also separates them depending on their beta-catenin and BARF expression. As far as surgery is concerned, I think we really are looking at the fact that is it a cystic lesion, how much is the calcification, or is it a mixed lesion, which is the most common variety which we come across. And all the books of operative surgery till about 2000 or the last century have talked about various approaches depending on the direction of growth of the tumor, and almost all of them have talked about the microsurgical approaches. The concept that the transphenodal surgery can help cellular craniopharyngioma is very well accepted. The question mainly remains about large supracellular tumors, especially if the sella is not widened. And choice of surgery, I think for cellular tumors, as I just said, it's transnasal, either microscopic or endoscopic is your choice. Intraventricular tumors, which are relatively rare, can either be treated with transcranial, intraventricular, micro or endoscopic approach. It is the supracellular tumors which require greater degree of individualization. So this is a no-brainer. I think everybody would treat this by transphenodal approach, either endoscopic or microscopic, and this is one such example. This is a 13-year-old girl who presented with this cellular kind of a tumor. You can see the cyst. The challenge is how do you separate this cyst from the remaining or residual pituitary mass and the stalk, and it has been possible to do this because of the good endoscopic visualization, where you can actually treat. It is not only a pull procedure as it used to be sarcastically called earlier. You can actually properly dissect sharp as well as, and this is the post-operative scan. You can see a good excision has been achieved in this patient. There is a very nice paper from the Italian endoscopy group which talks about all the cellular craniopharyngiomas, or infradiaphragmatic is probably a better nomenclature, by Dr. Solari and Capabianca's group, but they have taken all the cases treated about at 6 different centers and 84 patients, and I think everybody agrees that this is the best way, and it is probably a little different type of tumor in consistency as well as in terms of operative challenge compared to the supracellular tumors. What about children? And in children also, I think it is easily possible, and most people have been able to do it in children as well. We have ourselves published about this, that apart from the restriction of pyriform aperture in children below 3 years, you can probably do it in all other children, and if you take care of blood loss and if you have proper instruments, and we've written about 40 such cases. Even pneumatization of sella is not a major issue if you have a navigation system, which is now available in most modern neurosurgical theaters, and it has been possible to resect this kind of craniopharyngioma also completely. So I think the prechiasmal tumor, where the morbidity is much less, if you do it transcranial or endoscopic endonasal, probably have the same result. I think the biggest advantage that has happened with endoscopic surgery is in the retrochiasmal tumors, where the morbidity was higher in previous literature, and it has been shown very clearly that these are the kind of tumors which are treated best with endoscopic endonasal approach. And this is a beautiful paper about the triple axis topographical model by the Spanish group, who have shown that this actually shows you that the infundibulotabular craniopharyngiomas, the supracellular retrochiasmal variety, are probably best treated with endoscopic endonasal approach, as the hypothalamic injury is much higher in transcranial approach. When we talk of endoscopic endonasal approach, I think this classification of CASAM comes very useful, rather than just retrochiasmal or prechiasmal, that the pre-infundibular, retroinfundibular or transinfundibular approach, and the pre-infundibular remains most easy thing to probably do. If you do a small extension into the anterior cranial fossa, you can get this tumor out quite well after ligating the anterior intercavernous sinus, and you can get to this tumor while preserving pituitary, as you can see at the bottom here, and you can actually get even the third ventricular component out quite well maintaining good function of the patient. In transinfundibular, the decision to sacrifice stock or not depends on the premorbid condition of the patient and how you find it. Here, I'm trying to take out the calcification from infundibulum, which is not always easy, and you have to occasionally decide to leave some part of the capsule behind if you want to preserve the stock. In retroinfundibular, it becomes a more difficult procedure, but if you drill the dorsum sellae well, you can get a very good access like you will find in this patient, and we have been able to not only achieve this, we have been able to get a good excision even in this patient. Recurrent tumors, I think, can also be treated quite well, like one of these patients. If it is otherwise well suited for endoscopic endonasal approach, then even a recurrent tumor can be treated well. As you can see, you can achieve a good dissection and preserve the stock even in a recurrent patient if the primary surgery hasn't already destroyed it. I think Dr. Prakash Nair from Sri Chitra has specifically written about the recurrent tumors recently, and they have also put a nice video on Neurology India to demonstrate this. A slight extension, if you do not have a very narrow neck, you can even remove from the, from the lateral extent, if it has not gone beyond the carotid completely, and here we have been able to remove the tumor. You can see from the sylvian fissure, and you can see the middle carotid bifurcation here quite well, and a good excision. In tumors like this, in a very small child, we have first done a endoscopic fenestration of the cyst, treated this patient with alpha interferon, and then when the cyst became too small, the question is of giving this patient radiation, or this was a recurrent tumor to begin with. Operated at the age of 2.5 years, and the patient preferred to undergo surgery. So the same opening, we have been able to excise this tumor completely. This is another tumor treated endoscopically, transventricularly. A complete excision has been achieved. I've written about our experience in this article in Frontiers. When the patient presents with raised ICP, I prefer to do a cyst drainage rather than putting a EVD or ventricular catheter, and then go after 3 or 4 days and remove this tumor completely by endonasal approach like in this patient. And the biggest advantage we find by this kind of approach is that the separation of the capsule, especially in the hypothalamic area and the lateral wall of the third ventricle, becomes much easier, and it is possible to remove the tumor completely in this method, and we've written about this as well. When you cannot remove this tumor completely, adjuvant treatments like radiosurgery, proton beam, etc. have become quite useful. So today I would like to do microscopic transcranial surgery predominantly for a paracellular tumor if there is very heavy calcification, vascular encasement, which is not very common in craniopharyngioma. And I think previous radiation, the only patient I have damaged during surgery is a patient who has had previous radiation, and that probably did not allow us a good separation from the nearby vascular. So even in transcranial surgery, as you can see, you remove this tumor through various corridors which are available, and then you can actually make sure that you have been able to remove this completely by using your endoscope like you use in many skull-based surgeries by transcranial approach, and make sure that you can get a good excision. We have used this combined approach several times. This is one patient where I first used a transcranial approach, and then remaining tumor we were able to remove by transsphenoidal approach, and you can see in spite of these two approaches we have been able to preserve the pituitary stalk, and the patient does not have diabetes insipidus at the end of the day. So I would not say endoscopy is the best, but I think it has certainly offered us a better alternative in several situations, and it has given us a possibility of more radical resection with preserving function in this patient. And this has been also brought out recently by a paper in endocrinology, where people have shown that the results of endonasal endoscopic surgery are probably better than microscopic transcranial surgery in terms of hormonal preservation. But I think the last sentence I would like to put is that individualization is necessary in management of craniopharyngiomas. I do not think we have a final answer yet. Thank you for a patient listening.
Shekhar, I would like to ask one question. If you are operating through the nose for an essentially supra-diaphragmatic or intracranial craniopharyngioma, and there is some bleeding from anterior cerebral artery branch or whatever, how much safe you are from controlling that bleeding in a bloody field. It is not going to be just trickle of blood, it will be quite a bit of blood. To get to the, when you are get an endoscope, get to the feeder, handle the bleeding, and if necessary take a suture. How comfortable are you when compared vis-a-vis to intracranial when you are going, can you answer that question?
So I think all this depends on, Atul, we have actually come from a generation, we started everything transcranial. Today I think there are already in this hall itself, you will find surgeons who have experienced more with endoscopic surgery than microscopic surgery. They will probably find it easier. Your question is correct. The main reason when we were doing single nostril surgery and good instrumentation was not available, this was the most important thing. Actually, it became a matter of life and death. Today there are special bipolars available. Today we are doing this surgery as a binostril surgery, so we can dissect as well. In terms of controlling bleeding, endoscope still remains an inferior instrument because it can get flooded very easily and destroy your vision. That is the most important thing, and it is a question of how you get used to it, but it is possible to do it. And especially if you are not using holding the endoscope yourself, like in two nostril approach, it is possible. Is it easy? No, it is not easy, and fortunately in craniopharyngioma it is not such a big deal. I think it becomes a problem with mainly with meningiomas and occasionally with chondromas, chondrosarcomas, that you can do not find a plane of dissection between the artery and the tumor capsule. I think it becomes a problem only for recurrent tumors or radiated tumors.
Any question? No, any question? We have 2 minutes specified for this. Any question? Maybe as Ashish says, questions come later. Sure. Ashish is the next speaker and he has to put a point, yes, transcranial. And he can also put a point, no, not endoscopy.
Thank you very much. At the very onset, I thank Professor Sharat Chandra for giving this opportunity. I must thank Professor Dev Pujari for his excellent exposition, and I also congratulate him for actually surrendering all his points in my favor actually. So I know that he is a great friend of mine. I admire him and I respect him, and if I have to have a craniopharyngioma surgery, I'll definitely go to him straight away. Now the issue is, we know that craniopharyngiomas are 0.2 to 4% of intracranial tumors in children, and they have got a bimodal presentation. The children with 0 to 14 years and adults above 50 years. The question is, till now there is no double blind study to prove the superiority of endoscope over microscope. So again, as was told, it's equivocal. But then you have to understand, till date microscopic surgery has been the gold standard to operate on all varieties of craniopharyngioma, cystic, solid, going anywhere. But the story of excision through endoscope is not so rosy as it is pointed out, and because I do both, I know the problems. So what is the data that we rely upon? This is a study, 2016, where they compared between the two procedures. They have taken two groups of patients. The endoscopic one was 9 and the microscopic were 12. And look, they carefully weeded out the pediatric patients, the revision cases, the tumors which had bigger size. And then after doing all that, choosing and taking the rosy things, which can be easily done with the microscope, I am sure, the CSF leak is 2 out of 9, which means 22%. So you are putting another morbidity for the sake of just using a fancy endoscope. You can do it again transcranially. Small tumors can come out easily without much problems. And then they say in selected confined cases you can do endoscopic excision which do not have significant lateral extension, and they confess that a multi-institutional collaboration is very much needed. This was a cystic lesion in a child which somebody has shunted also. I went transcranial, the whole cyst came out just like that very easily. You can do that. So you don't need to always use an endoscope and go through the nose. Why? I'll tell you later on. Because it's a child, the cella is not formed. You have to then make all sorts of burying and changes in the skull base. Another study, 2020, where they again compared these two studies, and here they look at the tumor volume, 14 centimeter cube, small tumors. And they are comparing these for deciding which one to use. And they have given excellent result in both. But the CSF leak remains 19%, and they have used nasoseptal flap, and then again the CSF leak is 10%. So again, you are defeating a purpose, giving another morbidity for no reason. And then they say that, well, both are equally good, and they say transcranial surgery has greater gross total resection. So this is there. Though they claim that visual outcome is better through endoscope, but the CSF leak is still high. So we are not there actually. So we can infer from these. I can take you n number of studies like this where the pediatric population is a problem. Small size are the ones which are chosen to prove the purpose. They have to be strictly in the midline without lateral extension, because that becomes a challenge. This sort of tumor, you can easily remove through the transcranial procedure microscope. They will come out, I tell you. This is a child. Again, the sella is not formed. You drill and you destroy the nasal cavity and then you enter. What's the purpose? You can remove it through the cranial root. So this is the case. You had this tumor, transcranial root, everything is gone. So that's possible because we've been doing it for ages, and we are trained in doing that, and we are apt in doing that as well. This is a calcification. Will not come out through endoscope. Not so easy. Transcranial is going to be better. You will see everything in front of you. So look at the corridors you have got transcranially. You can go through the carotid-optic corridor, you can go through the interchiasmatic corridor, and that's how you can sort of, take out the things. Just to give you examples, the calcification, they can just be gently peeled off. It's not so difficult at all, because if you are regularly doing it, you know the tricks to do, and you can even save the artery. The point which Atul made, the artery you can see here, and if there is a bleeding, you can control it directly. And then, at the end of the day, you have a clean field with all the tumors removed. So just small bits of video clips which I took for presentation. The main problem here, which I would insist, is that nobody talks of the morbidity of extended endoscopic endonasal approach, where the patient has to pay a heavy price. Now this is not discussed, because the surgeon does the job and leaves it to the NT surgeon to take care of all the problems. Main problems are CSF leak, infection, and long-term issues of operating through the nose. Main issue is healing. And I've just taken an example of what are the advice given to a patient in the West in a hospital after a transnasal surgery. Don't blow, don't cough, don't sneeze. If you sleep apnea, use CPAP, don't smoke, don't lift anything. So many restrictions for a nasal procedure. Then the incision. There's a nasal crust, there will be congestion for several weeks. You may lose your sense of smell. And then you have to spray decongestants and salt water, and that's what you have to go through after a nasal surgery. So you remember that these are not discussed threadbare actually. And then they say you have to go to the ENT surgeon 1 week later, then you have to pay 2 to 4 ENT visits. There will be encrustation in the nose, for which you will need washing and cleaning, and then they rinse the nose and remove the crust. So all these are advice from the hospital. So that's what is told. So you see what you are giving. So are we really minimally invasive any standards? Because that's the issue. If you're given another morbidity of a patient to carry on for months after the procedure, we have to be careful about it. Transcranially, you do a thing, the scar is hidden, you don't have all these problems in that standards. The second question which I still harp upon is, are we protecting the nasal anatomy and physiology, or are we systematically destroying what nature has given us for our survival? Why? Because nasal mucosa is important for flow of air, and it contains the particles which go to the nose. It not only produces mucus, resorption of the fluid, but also has hemostatic effect, and immune response is there in the nose. And you are also, when you are removing all this mucus and making a wide approach, there are several transitions which happen. Nasal edema, vesicle formation, granulation tissue formation, many polyps, fibrous hyperplasia additions. I have seen that, patients coming. I'll take you one step backwards. Paleobiology of the nose. Nature has created the nose, the turbinates, to contain the humidity which we lose in our respiration, and also to save us from the pollens and other things to go in. So this is over the billions of years, millions of years, these have developed. And the turbinates, they not only warm the air, they humidify the air, the mucosal layer filters the particles, and there is prevention of water loss from the body. And there is a nasal cycle which happens. The nasal turbinates every 7 hours go into congestion and constriction. And this is an important phenomenon which is very important to recharge your nose and the glands and the mucus, clearing the mucus and easy flow of air. So all this physiology is not considered when we consider. So this nose, beautiful nose on the left, is converted to a hollow playground with everything removed and washed, cleaned away. So that is what we are achieving. Are we really doing the good thing? We don't have an answer. Somebody is allergic rhinitis. So you remove all the terminates. The allergens now have free access to the straight away into the lungs. So in the long run, after 15, 20 years, in that sort of patient, you'll know what's happening. And this is what you do. It's a huge hollow cavity. There's none of the structure of the nose sitting there. This is just an article where systematically they have just analyzed the complications of just pituitary surgery. And I am telling this on the experience of doing 1,500 pituitary surgeries till now. 20% cases, these are small complications. Patients do complain, we just tend to ignore them. You can have hemorrhage, CSF rhinorrhea, sphenitis sinusitis, atrophic rhinitis of olfactory disorder, perforation of the nasal septum, nasal adhesions. These are very, very common. Bleeding, which you need to go in again. Synecdoche, yes, it can happen in nasal surgery. Osteitis, if there is inflammation, granulation tissue formation, the underlying bone can undergo necrosis. Olfactory disorders, they do happen. We don't really analyze them properly. So hemorrhage, deep electrocoagulation, tight nasal packing, these are also not safe, not good for a nose. And then you go through all this treatment, antibiotics, nasal douching, nasal packing, infection, the patient repeatedly coming to the hospital, and then you go through a host of all these problems. Nasoseptal flap is a very important thing. We know without that nowadays we don't consider transnasal surgery. But mind you, there are significant issues with nasoseptal flap also. We say that it prevents CSF leak. How much has it prevented? It has improved the CSF leak from 15.6% to 6.7%. So it's still not near any normalcy. So 7% patients are having CSF leak. So if you manage the complications of that. There's a beautiful review of the complications of nasoseptal flap which has been published in 2018, and the authors clearly say the complication of morbidities associated with the reconstructive flap are poorly understood. They don't understand why the complications occur in many occasions. And although the complications are associated they are grossly underreported also. So we tend to just ignore it and brush it off. But then it is the patient who is at the receiving end of the whole situation. And this is a compilation of 27 articles on nasoseptal flap. And you can see the list of complications which can happen in a nasoseptal flap, starting from necrosis, mucocele formation, septal perforation, nasal dorsal collapse, and the effect on the quality of life and the olfactory loss. And as a add-on effect to that, you can develop pneumocephalus, epistaxis, intracranial bleed, meningitis, sinusitis, pulmonary embolism. Do we discuss all this with the patient? I'm sure we don't go into that sort of details. That will scare away the patient. Some of them can happen the transcranial route, but yes, not to that extent, the way it is. So this is a CSF leak in a nasoseptal flap. And this is nasoseptal flap necrosis. Probably there was a narrow pedicle not done properly, and that was leading to this sort of situation. And once it is there, be sure there will be underlying meningitis, and you can have all sorts of complications because of that. The other thing which is very important, lumbar drain. There is no consensus of which one to put a lumbar drain. There are some surgeons who would go straight away for a lumbar drain. This article where 82.4% of the patient. Others would use it when there is a high flow CSF leak. So that adds to another morbidity to the patient. So that takes us to the issues of whether we have to really consider. So you have to be judicious really when you are going to use a nasal procedure. But most of these can be avoided if you can use a transcranial procedure in experienced hands where the results are almost the same or sometimes even better than endoscopic approach, because you can see things straight in front of you. The olfactory issues. The University of Pennsylvania smell identification test was carried out, and after an extended endonasal approach, it was found that after 6 weeks, there was a reduction in the smell in a significant number of patients, which took 3 to 6 months to improve. So the patient had to go through that difficulty again for such a long period of time. So I would like to conclude that endoscopic surgery for craniopharyngioma has a long way to go. It is, I am not dispensing it totally, but yes, there are issues. We don't tend to accept that. Given the concept that it is minimally invasive, it actually defeats the purpose in all aspects. Morbidity is associated with the procedure and is highly underrated. Microscopic surgery can be done in a very good way by an experienced surgeon in a very effective manner, which has got far less morbidities than which I have enlisted. Transcranial approach, first, another thing is that gives the freedom to successfully treat all the cases. So I would like to infer, rather than being a minimally invasive approach which is meant for prompt discharge, morbidity-free recovery, the endoscopic, extended endoscopic approach invites a host of issues, and we must remember that. The risk of prolonged hospital stay is there. I would discharge the patient of craniopharyngioma in my hands in 4 days' time. It warrants repeated post-operative visits for the care of the nose, and that goes to the ENT surgeon, so we don't see that. There is increased cost of care, obviously, and man-hour loss to the patient. And of course, it jeopardizes the freedom of life in the post-op period, specifically if there is a problem with the olfactory nerve and other issues of the nose. So sometimes in the garb of avoiding a craniotomy, which the scar would be very well hidden under the head, and cosmetically it won't be not at all that bad, we are actually performing a mini craniotomy through the nose and then trying to reconstruct it and destroy the nasal structures. So it will take a long way to understand the consequences of deliberate destruction and harm we are doing the normal nasal anatomy and physiology. Might be some 10-15 years down the line. If somebody does a randomized study, if it is possible, or compare these studies and see this patient, the follow-up, they will know what these patients have to say. Thank you very much.
Okay, now there will be quick questions, okay, and quick answers. Now, Ashish, is there any indication for transnasal surgery in your estimation? Dr. Depujari, can you come up, please? Quickly answer, please,
Yeah,
because
if there is a simple tumor, cystic tumor, which we can remove like we do the pituitary surgery, yes, I would go and remove it, no
simple
problem.
means what? Is there some anatomical, morphological features?
Yes, if it is not going lateral, if it is, very easy right in front of you, like you do in a pituitary tumor, which is coming to the sella, I would definitely go and remove it through the sella without distorting the nasal end. My main worry is the amount of nasal dissection sometimes is done, which I have seen in my own eyes, and the ENT surgeon then struggles to take care of the patient, is something which is very baffling.
Okay. I will appreciate one-line answers if possible.
Yeah.
Yeah, Dr. Depujari, what do you think? What are your indications about transcranial today? Not literature. Today, what is your indication?
I think if there is a paracellular extension substantial, I would certainly consider transcranial as the first approach. A patient who has been previously irradiated, lot of calcification, I would consider transcranial as the first approach.
Dr. Ashish had mentioned about CSF leakage, which is a big issue in transnasal surgery, particularly in craniopharyngiomas, where you leave such a huge cavity full of CSF and third ventricle, which will be right exposed in the sphenoid sinus. What is your experience of having CSF leak, and were there any cases where you had to reoperate and ultimately you were not able to control? Can you answer that question?
I have had this problem in chordoma patients, especially the ones which were previously irradiated. In our series of craniopharyngioma, exclusively operated by transcranial approach, about 53 or 54 cases, we have not had to go back again for doing a CSF repair.
Never in craniopharyngiomas?
Not in craniopharyngioma, luckily. I have had to do it for an epidermoid patient, I have had to do it for chordoma patient, but not for craniopharyngioma patient.
Okay, very burning questions. The concept of minimally invasive is to have a maximum preservation of function and minimize tissue traumatization, not only to the brain, but also to the corridor. And Dr. Ashish has listed out a lot of complications related to nasal mobility. So maybe Prof. Chandrasekhar Jopujiri, would you like to dispute or agree with all the list of complications that she mentioned pertaining to the nasal morbidity?
For nasal morbidity, I think it is essential, at least I believe, that this is a two-surgeon surgery and ENT surgeon is a very important component of your surgical team, because he usually takes care of the post-operative. Many of the problems he has mentioned are real, but they can be avoided. The second point was which patients are likely to get CSF leak more. I think there you need to use various other ways of clearing this. But I think most of the nasal morbidity you have to depend on your colleague, and if he is involved with you right from the beginning of the surgery, we know how to avoid, like we know how to avoid complications of a craniotomy. If you are doing the craniotomy yourself, it is the same situation.
Just to ask a quick question, what is your strategy for preserving the stock? Are you actively pursuing it, not pursuing it? What is your strategy? Ashish and then Shekhar. Quickly.
I would preserve the stock always. For that, if a small bit of tumor is left, whether transcranial or endoscopic, it's very important. Stock is something very precious.
How often you are able to do that?
I think I just leave a small bit.
The small bit leaving is...
Small bit is something which is just stuck to the stock under direct vision. I would just leave a slather of tumor around it and that's it.
Answer my question. How many times you are able to preserve the stock?
I preserve the stock anatomically every time.
100%.
That's my motto.
Shekhar?
I think one of the advantages of doing endonasal endoscopic surgery is whatever you want to preserve, you see very well. Much better than what you can do in a transcranial approach, where you need to use several corridors to make sure that you are saving it. In terms of preservation of stock, if the patient has preoperatively severe endocrinological deficit, then I am not too much worried about preserving the stock. And I think it is only the transinfundibular variety where stock dissection or preserving the stock is a huge problem. I think in pre-infundibular patients you can probably save the stock almost every time.
Questions from the audience, please keep them ready. Basant?
Yeah, so you asked that question, when do you do both of them? I mean, the indication I take with the both of them, but I think there are a couple of things which very you need aspirin cannot.
Mike.
To my mind, you cannot, and it's not advisable to do an intraventricular tumor through an endonasal
Absolutely.
approach. And the other thing is a tumor which is heavily calcified and extensive, like you said, number one. Number two, there is an economic reason also, or the professional reason. Now, this is a pilot there, or a patient whose livelihood depends on the driving. I think it's critical, it's a huge difference whether you do a transcranial, because once you do transcranial, he loses his license, and so he may lose his livelihood. And about the stock, I think it's not critical in an adult patient so much as in a pediatric patient. And in an adult patient, especially, and again, whether you like it or not, its economic reason is very important. Because today we have all the possibilities of taking care of the endocrinopathy in a patient who can afford it, whereas the patient for a death sentence for a child from a village who cannot afford it. So I think that in mind about stock.
Wait, and yeah, Sharad.
It's been excellent exposition by both the speakers with a lot of experience. My question to Professor Deo Pujari, I mean, are we underrating the nasal complications? For a pituitary, it's quite okay as long as it's not extended. But once we do an extended, like Professor Ashish Pathak was saying, how much do you think are we underrating the nasal complications?
I think one of the biggest differences that has occurred, this has been a problem which we have discussed with several of our visiting faculties. We've been conducting these workshops with several people, and one of the things which has come very clear is one technique which reduces the nasal complications substantially and is not being followed frequently by many people is what is called the reverse flap covering the bare septum. I think if you are doing a binostril approach, you have a unique opportunity to cover your septum completely, which reduces your complications of nasal synecdoche and frequent crusting. which is the main bugbear of extended approaches. And I think that one step had changed our post-operative complications substantially.
In one article in World Neurosurgery I had written, endoscope looks good, but its patient has, it smells bad and leaves a bad taste in the mouth. Is that sentence good or not so good?
No, I think this is all with reservations. Like every surgery, if it is well done, it does not create problems. If it is not well done, then I think it will create complications. I would like Dr. Goto to please make a comment. But just one more thing I would like to say.
I have just one comment to this discussion. Transcranial microscopic or endoscopic endonasal approach. This discussion completely matches the topic of this meeting from concept to practice.
Correct.
In conceptually, basically the origin of tumor is a pituitary stalk. Craniopharyngioma located the pituitary stalk. Pituitary stalk is completely within the circle of Willis. So if we directly access the origin of the tumor, conceptually endoscopic endonasal approach is the best way, because all perforator or critical structure is the lateral side of the tumor. So if the technically the well developed, I think the endoscopic endonasal approach is the best way to resect the all type of the craniopharyngioma in my hearing. But the problem is even now the endoscopic technique developed day by day. Just some center can perform the good surgical procedure, but even now every institute cannot perform the endoscope well. So the clinical paper, the CSF leakage is over 20% or 10%. But if familiar with endoscope, the risk of CSF usually less than 5% or 3%. So not so problem. So this discussion is completely very difficult. But I think in near future, I think the doctor try to resolve by the endoscope. This is my comment.
So thank you very much. Because of the time, yeah, quick.
Vicky.
probably more important than the others. So I think we have to, I know we probably don't in terms that we're going to treat the brain in a slow-based case, but there are people who do that, and it isn't trivial when we use big small parts of the cortex. And we've known the orbital cortex is important for judgment for over 50 years. So I think that while it's important to talk about nasal mobility to build, we also have to make sure that we're honest that going to the brain has risks and mobility, specifically in the brain.
I think only one sentence I would like to say. I think the endonasal surgery for this kind of a tumor is not minimally invasive. I think we are really talking of minimal access surgery. We are not talking of it is probably more invasive in terms of removal of bone and getting the tumor out properly.
So essentially, the controversies are not whether in craniopharyngioma, one controversy is whether to come from nose or from here or from there. But craniopharyngioma in itself is quite a controversial subject, particularly when we talk of pituitary stalk preservation, radical resection. Role of radiation is also not, it is undervalued. It is not so bad, role of radiation in craniopharyngiomas, whether to remove partially, whether to remove a small bit and all. So I consider craniopharyngioma as an unfinished chapter of neurosurgery. I hope it will finish sooner than later. Dr. Azmi, your comments and we close it.
I think we had a very good discussion. We can continue during coffee break because we have to respect the time. So I thanks everybody who involved, especially to the two speakers. Thank you very much.